Hello, Dr. Kim.
Hello, welcome to SNU Hospital. I'm HS Kim, main operator for this live case. My colleagues, BK Koo and HM Yang and JQ Han. We have many fellows and technicians there. How are you? How is the
Excellent.
Congress today?
Very good. Very crowded, so you have a full audience. We wish you a lot of luck, but knowing that you don't need luck because of your expertise, we're expecting a perfect case. So the burden is on you.
No. It's, I really like a gallery. So if galleries are few, not motivated, but if there are a lot of galleries, I try to do my best, our best. Okay, let me introduce my case. Slide, please. History is a severe aortic stenosis diagnosed at outside hospital during a pre-op routine check. Upon diagnosis of severe symptomatic aortic stenosis, they refer this patient to our SNU hospital to correct symptomatic severe AS first, and then they try to do osteoarthritis surgery. And we discussed the patients, which one would be better for the patients, and under the HOT team system, she acknowledged that surgical merit, but she refused finally to undergo surgery. But most of the Korean people really hate to undergo surgery. So even though she is 70 years old, she decided to undergo TAVI. Next slide, please. Clinical presentation is severe symptomatic AS with bicuspid aortic valve. No significant comorbidity. Next. Echocardiography shows severe symptomatic AS with bicuspid aortic valve as a result of fusion of right and left coronary cusp. Mean pressure gradient about 60 torr, peak pressure gradient about 90 torr. Next, please. CT angiogram shows a severe asymmetric calcification on bicuspid aortic valve. Next, please. At the lower level, we can see severe asymmetric calcification extends to LVOT. That is very important sign to predict prognosis of TAVI. Total calcium score extends 900 cubic millimeters, severe grade. Plus, there is a huge association between calcification and leakage. There are two factors of calcification. Total calcium burden is important, as well as location or distribution of calcification are also important. LVOT calcification, eccentric calcification is poor sign. On the left lower panel, heavy calcification with LVOT involvement is very important. On the left blue box, where LVOT calcification is minimal, then association between calcification and leakage grade is not significant. But on the right yellow box, where LVOT calcification is substantial, then calcification is correlated with leakage grade. On the right, eccentricity is very important also. Next. Regarding eccentricity of AV calcification, conventionally, leaflet-based method was performed. They calculate maximum difference of calcium between most and least partition and assessed eccentricity. But we recently suggested new bipartition method. Maximum difference of calcium assessed between most half versus least half. Next, please. Two methods are compared in the same patients. For example, in bicuspid AS patients, traditional leaflet-based method, just difference is 70 cubic millimeters. But in our new bipartition method, difference over 1,000 cubic millimeter, severe difference. Lower patient balanced calcification, traditional method, difference of calcium between most and least sector is just 200. In our new method, over 800. Total different in some cases. Plus, then which one is better? We assessed two methods in 85 patients with core valve treatment. On the right, precise prediction power of bipartition method is better than traditional leaflet-based method. On the left, bipartition method is better than just total calcium assessment. Thus, when we combine total calcium and bipartition eccentricity measurement, we can well predict the moderate regurgitation. For example, total calcium load is more than 700, and eccentricity is more than 272. The risk of moderate regurgitation is very high in case of core valve. Plus, how is this case? Live case total 900. Leaflet-based classification eccentricity is just less than 100, but in our bipartition method, 300. Right side is criteria to predict moderate regurgitation. Total calcium burden is high. Bipartition eccentricity is high. Thus, these patients is high-risk patients of post-TAVI paravalve leakage. Plus, then which kind of valve type should be selected for this case? Bicuspid AS with eccentric LVOT extended calcification is highly associated leakage, AV block, and latte. Thus, I would like to avoid balloon expandable valve and choose self-expanding valve. Considering high risk of leakage, rather than Eberhard, I'd like to choose Lotus because it has adaptive seal to minimize leakage. Next, please. The other issue is device size. Measurement results is shown here. In our SNU hospital, size is 22 by 26. Company, 20 by 26. That corresponds to 25 millimeter valve. Next, please. When we choose 25 millimeter valve, it reaches oversized by 5 to 7%. But when you choose 23 millimeter valve, it reaches undersize by 1 or 3%. Undersize is a high risk factor for leakage, but it is the Lotus valve. Plus, so when we select smaller size valve, concern is leakage. When we choose regular size valve, the concern is complete AV block or annulus tear because of the alveolar calcification. Thus, we decided to do balloon predilatation using 20 millimeter balloon for assessment of annulus. Annulus size is about 19 or more. Thus, we chose 20 millimeter balloon. When it is fully expanded, the actual out diameter is about 19 millimeters. Plus, this is our experience with Lotus 12 cases. AV block, annulus tear, leakage, mortality, all perfect. Just permanent pacemaker was implanted in the first case because she showed permanent complete AV block immediately after ballooning. Thus, I decided to do a permanent pacemaker. We satisfied that performance safety of Lotus, but the company still continue the innovation, next please, to produce Lotus Edge valve system with several good things. Additional valve size, 21, 29, and shallow sheath down to 14 French. This is a presentation, our plan. Is there any comment, question?
No, I think we got this message from you, and it was very interesting, actually.
It's a quite challenging cases. In your 12 cases with a Lotus valve, is there any cases with a bicuspid valve?
I don't remember, but 3 or 4 cases, probably a bicuspid. And all the results are really perfect. No regurgitation. Thus, especially in the case of bicuspid, I usually try to select the Lotus valve.
And usually in the patient with a bicuspid valve, there is a more tendency of some under expansion. So in that case, we need the additional balloon. But in the Lotus valve, the additional balloon is not usually recommended. So I think your case is some provocative and challenging attempt.
Okay.
It's a bicuspid with very severe calcification. So I disagree with you. So we'll use the smaller size of the Lotus. So it's low risk for the public, and on the other hand, so it's also it's easier to be positioned. Yeah.
I think this is going to be very interesting because the question is still open on bicuspid valve measurements, whether the classic annular measurements are the correct ones for sizing. Personally, I don't believe so. So classically, the bicuspid valve never reaches the complete annulus, and I think we're actually doing too much, or you're oversizing by annular measurements. I would probably in this case also look at the combinated diameters of the opening and judge on that, because now you have risk in the left ventricular outflow tract calcifications and calcification in the leaflet. So this is going to be very interesting to see how Lotus behaves in your expert hands with this difficult patient.
Okay, let me show you the progress until now. The first angio, we usually puncture the common femoral artery on the guidance of fluoroscopy to puncture the center port of anterior wall of femoral artery. Plus, this is a cine fluoroscopy to puncture the femoral plus. Then introduce 22 French shears, seeing all the process to prevent vascular damage. Plus, then perform root arterography in AP view. Even though there is bicuspid, but we can see the three sinuses. Center right sinus is a little bit low. Thus, we repeat arterography with caudal 10 plus. This is another arterography with AP caudal 10. Right sinus meets with left and none. Thus, we decide this angle as a standard angle for the next procedure. Plus, then I introduce the straight wire into the left ventricle under the guidance of M+ coronary catheter plus, and advance catheter plus, introduce the shaped tip guide wire and plus, exchange the catheter into pigtail to measure the pressure difference between aorta and left ventricle plus. The pressure difference was about 70 torr, and then change to the suffering wire plus.
Nice.
Then perform balloon valvuloplasty using 20 millimeter balloon to assess the actual diameter of annulus with dye injection. How do you think of?
Yeah, this is very, very important for the audience and for the panel, I believe. It fulfills actually two purposes. Number one, you do the classic pre-dilatation, but also now with the injection and the 20 millimeter balloon, you know that the 20 millimeter balloon seals the valve. So this is a very, very good, I think it's a very good step for secure sizing and pre-dilatation in the classic sense.
Thus, we chose 23 millimeter valve.
Very good.
It takes 10 minutes to prepare the valve. The lifetime is just 45 minutes. Thus, I perform balloon valvuloplasty already to make the time for preparation. Then, timely, the 23 millimeter valves are prepared. Thus, we are going to transmit a live procedure.
And also you can notice that the calcium is being pushed towards the orifice of the left main.
Very nice, very nice point. Exactly.
So would you consider protecting the left main with a wire or?
What's the height of left coronary artery? 이태민 선생? About 14? Left coronary austere height가 얼마인지 한번 가르쳐.
So 14
Huh?
to 15.
14 millimeter. Thus, I'm not concerned about the possibility
you should
of
be alert. You should be alert.
Okay.
The movement of the calcium toward the
자, 좀 이따
diastema is a kind of the bad sign.
The only thing is with Professor Kim, he likes to implant Lotus extremely high.
Yeah.
And having said that, if you're very high, you have to pay attention to the takeover of the left coronary. Okay, here we go. He goes in, the marker goes to the right.
Okay, 전체. 그리고 Okay, mark is right side. We installed a new machine this month. I'm on vacation. This is the first day to manipulate new machine. Please understand. Okay. 잠깐.
Now he opens up to LAO. He opens up the arch to see
Yeah,
how
LAO.
the valve will cross the arch.
The marker is right side. This is pre-shaped on contralateral side. Thus, when we maintain this shape, it has the least risk of aortic damage. So I advance. So smooth
Goes easy and smooth.
and into
Enter.
LV. That's best angle.
I guess in this case, if you have a coronary issue, you could just retrieve the
Pigtail is
valve.
distorted.
It's a really good valve to choose.
Dye injection, a little bit, test it. Okay.
He's securing the position. You know, the pigtail is free.
Pigtail is freed, but it is kinked. Okay. The alignment is not good between aorta and device. But anyway, we have to start. Just deploy, unsheathing.
So they start unsheathing,
Yeah,
and you can see the braid has to be below the annulus.
this stuff and the frame, valve frame is below the annulus. Test it. Here. Okay.
And for the audience, there's the marker that comes down. The marker is the dark dot that you can see on the left side. As he deploys, the marker will come down. Now the valve flares.
Test it. Okay. Test.
When the marker is in the expected, now the marker is close to the pigtail. The valve is already functioning and the waist is beginning to form. Very nice at the calcification. See that? Yeah. Very nice. And so what we expect by the tricuspid valve actually, you have a fair, you know, it's both sides push the valve in.
여기서 그 앵글을 좀 바꿔가지고 트라이 포스트가 싱글 플레인으로 되게 한번 해볼게요. I'd like to align the 3 posts at the single plane. Caudal.
Yeah, because now the valve seats and the valve is functioning, patient is stable. Now the layover will follow. to
How
make
about this
the-
projection? I think the 3 posts looks at the same level, a little bit lower, caudal.
Maybe you can bring the Mac up
Yeah.
for us to
Right,
see it more
right.
clearly.
I don't like Mac.
Oh, okay.
Okay. Just, I'd like to show you more delicate image using Cine. Shoot. How about this? How about depth? A little bit high? No, I'd like to go on.
No,
Okay. It's a little bit further deploy. Then I'd like to push whole system a little bit to layover. 들어갔다. 좀 들어갔어. A little bit pop in, test. Not well fixed. Okay, just deploy.
so now the buckle and the posts are approaching each other in one line, so make sure that the two lock.
Test it.
Waist is formed very nicely on both sides, so the valve seals already, you can see that.
좀 더 푸시해볼까?
So the 23 was a perfect choice.
This is
The
the
valve-
layover process. Okay.
The valve shortens from low to up.
How about the conduction system? EKG 보여줄까? There is a conduction is maintained. I always check the conduction disturbance during the process.
Yeah,
We chose a smaller valve size. The risk of AV block may be lower. Okay, that's good. How about the level?
Yeah, the two posts on the right looks okay. I think the configuration looks okay.
yeah,
Okay.
the two on the right,
two on the right
that's
is
actually a
open.
perfect,
Yeah,
perfect
two on the right
image.
is open, the left is closed. So
Okay, 좋아. A little bit high, but I'm going to further process. Just 지금부터 이제 lead in.
Very nice.
Okay.
So the two approach each other.
yeah,
Yeah.
the gap is closing.
The valve is
How about
sealing.
the lead-in assessment? On the right two posts are really en face. And left one is good profile.
Yeah.
So I think the post alignment is good with buckle.
Very nice, I think.
Okay, can you proceed further?
You know,
Okay.
sometimes in the bicuspid heavily calcified, this is difficult.
Yeah.
You have to struggle to make the alignment, but I think now the alignment is.
Yeah, I would probably lay over a little bit more. You see, it's still going into the inner curve, into the minor curvature, but and the pigtail probably should come out too at some point.
Yeah.
Can you see the getting close to
Now he's getting close to the
color,
locking.
buckle,
gap.
and post?
Yeah, the gap is almost
Okay.
closed.
See it once again. How about the lock?
That's very,
Looks
very
okay.
nice.
When do you remove your pigtail, Professor Kim?
Anytime.
Anytime.
Yeah.
Okay.
And for
Because
the audience,
I'd like
you-
to see more
you can-
exactly the level with smaller amount of dye.
you
Okay.
can always retrieve the valve if so necessary until this point.
Okay.
So he pulls the
A little bit
pigtail
remove.
because it doesn't serve any purpose anymore
Yeah,
because
no,
it's-
because
the
you have
valve
the
is in
weights and everything
position.
already. Yeah.
Okay. Just 쓰네. Sure.
So as you can see, the process
How about the level? I think it is a little bit high. Okay, I try to recapture and readjust depth.
So the
Left main
patient
flow
is
is no problem.
yeah,
okay,
the patient is stable,
Yes, stable. Capture.
and now he recaptures. So he's going clockwise to resheath.
Okay. Do you see the recapture process?
Yeah.
Test it. Die. Okay. Recapture. Order. Okay, stop. Die test. Here, we repeat the unsheathing process once again. Okay.
See, the marker went up again. He pulled the valve back a little bit,
Test.
and he's going counterclockwise on the handle.
Deploy. 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 Deploy.
EKG and
Test.
pressure are stable.
Yes, stable. Deploy. Okay. Deploy. Test it. Okay. Deploy. Just lay over once again.
Yeah.
Okay, test. Okay. A little bit deeper than previous one. How do you think about the process? 조금 다시 앵글을 좀
You
바꿔볼까?
want to send the marker to the center of the pigtail. The marker is a bit high.
Yeah. 앵글 좀 조금 더. Okay.
I think it's time to check the lower margin of the with a TE.
Test it.
And the second one is if you proceed and more, it is some
Deploy.
more shortening of the lower margin.
Deploy. 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 자, 테스트 준비. 자, 테스트 준비. Shoot. Okay. How about this depth? A little bit better than previous one.
Yeah.
Okay. 자, lead assessment. 자, 다시 한번 볼게.
So the valve is a little bit higher. The marker is
Yeah, still
at
a
the
bit
upper
high.
point of the
Still
pigtail.
high?
Yeah, still a bit high.
A bit high, okay. Recapture.
Sorry.
Definitely lower start, okay. I really intend to high implantation, but regard adopting your opinion, I readjust the depth. Okay. Test it. Okay. Capture.
But it really demonstrates the beauty of repositioning and resheathing capability.
So what is your plan?
혈압,
Where do you
혈압
want
좀
to,
좀.
where do you want to put the valve?
혈압. 자, 테스트. Deploy. 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 Test it.
Watch the marker. The marker comes down,
Deploy. Deploy.
reaching the pigtail now.
Deploy. Test. Deploy. Deploy.
Better.
Deploy. How about this status?
Yeah,
Test it.
looks better. Yeah.
Okay. Deploy. Assessment. Not. Okay. Can you check once again? Okay. No die. It's good. Okay. Deploy. Lead-in assessment.
There is some new bundle branch block though.
Yeah. LVB. A deeper position.
Yeah, that's the price to pay.
How about lead-in assessment? It's good. Okay.
QRS is narrow again. I think the ventricular portion is being shortened. Yeah.
자, 여기서 테스트 한번 해볼까요? Shoot. The same position.
Yeah. No, it's a bit lower than.
The lower?
I
Okay.
think this is better.
Better? Okay. Deploy. Continue deploy. Locking assessment. Just simple, cine. Okay, good. Right.
Maybe you can rotate the, so that we can see from the other projection.
Most left one. 좀 더. How about? 좀 더 앵글. 오케이, 조금 더. Okay, once again. 스네.
So they're approaching, buckle and post are
How
coming
about
together.
the left one? It's okay?
The right and the middle looks okay, but I'm not sure about the left.
Left.
No, I think that the two on the left side, the tuning forks, are they okay? The right side also.
Okay.
If you are happy with the depth, I think it comes out nicely.
Okay.
So Eberhard, you think the most left one is also okay?
자, 스네 테스트.
The furthest left?
The most left one.
How about depth?
You have a TEE, so the just without you just depend on the force.
best angle?
You use the TE and
I think Professor Kim now is checking for the locking, not the position of the valve.
Okay.
So TE is
The best
probably
angle?
not helping. He's trying to make sure that the
Can you
knuckle,
see the
the
TE?
post and the buckle is not twisted.
Okay. 자, 여기서 the locked-in process would be okay. So let's focus on the depth. 자, test 준비, test. In another angle, test die. How about
Yeah,
repeat?
it looks okay.
Okay. How about T? Let them
Yeah.
show T. This is T. But can you see?
no.
Okay.
Yeah. The echo looks good though.
Yeah, no PVL.
Okay. 자, proceed. Remove T case. T probe. 자,
You know,
okay.
I still think that there's still tension in the system. It goes up, so I would probably put a little bit more. But
More
now
layover.
they're approaching, they're locked.
process. Go. Okay.
Now, did it click?
Yeah. Then there's no. Okay, cine. Sure. Okay, can you progress further? Nobody answered.
No, I think the left coronary is patent, no
Yeah,
problem.
yeah, no problem.
The pigtail is probably in a non-coronary, so you don't see the right coronary. But I think it looks,
Okay.
looks okay.
Go. Okay.
Okay, now he's going to the step.
Going to step to
where it
phase
is
one release.
irreversible.
Can you see the movement of center pin and? Okay,
Yeah.
phase 2.
Yeah.
Okay,
So the valve's being
three pins.
released now.
Okay. Just 또 감지
I
캡처죠.
actually don't like the pigtail now in that
No,
position.
yeah.
But anyway. So the valve's released now.
Yeah. 감지. Release.
He comes to a hard stop and then
Okay.
those are the supporting.
Released,
Okay, now the
yeah.
valve's free.
Yeah.
그다음 가이드 와이어 줄까요? 와이어 줄. So I removed the pigtail. On the guidance of guide wire for safety. Okay. Okay. Okay.
So the nose cone comes back now.
일단 감지. 저 가져가고. 물총. 오케이.
And the nose cone is being pulled back into the delivery catheter. The safari is in place.
Okay, captured. Okay. Wire stay.
The wire.
Wire stay. Okay. We remove the delivery system. Okay.
System is
pigtail.
out.
Very nice.
Looks like the EKG is good, no?
Yeah. Yeah.
This is arrhythmia produced from the stiff wire inside the ventricle. So
Yeah.
I changed to the pigtail to assess the pressure change between two chambers and assess the AR index, angio. 알아요. Okay. Pressure.
Is it now pacing rhythm? Because
No.
from here we can.
Probably accelerated idioventricular or idiojunctional rhythm. 자, 갑니다. Accelerated idiojunctional rhythm to 70 beat per minute.
Yeah, beautiful curve. No gradient.
아래로 진출하니까 미안하네.
Very good AI index.
So there is no ectopic beat, but I cannot
Very nice.
see the P wave. Still accelerated idiojunctional rhythm. Yeah, P wave is idiojunctional rhythm rate is declining. We can see sometimes P wave, kind of usurpation due to rapid junctional beat. Pressure gradient disappeared. Pulse pressure is very good, so we can calculate the AR index. Can you? Yeah, AR index 32. 32 means there is no leakage in, at least in hemodynamics. Then we can check the arterography to see the leakage.
May I see the final, the aortogram and the T?
Yeah. We can show
Very
all the
challenging
things.
cases and then excellent region.
Test it. Okay, I removed the ventricular catheter to exactly evaluate the leakage. For the safety, I usually retrieve the picture catheter on the guidance wire. Okay, it's the best angle. Just 아니 그게 좀 더 한데 저 3포스트가 싱글 라인으로. I'd like to change the yeah we can see it 조금 더. Yeah, 3 posts are in a
Very
single
nice.
plane. Then die 준비됐어요. Okay, let's get shoot. How do you think about it?
I think that's
It's
perfect.
good,
It's
yeah.
trace.
Yeah.
The valve sits beautifully.
Another angle, right
and
side.
you know, let's not forget it's a bicuspid valve.
Excellent.
And it's a very, very nice result, Professor Kim. Beautiful demonstration.
Okay, another angle. Shoot.
Good. Very good result.
I can
Yeah.
see such kind of a minor, trivial. You could say, is it due to transvalvular? Okay.
Yeah, I
anyway,
think
it's very frequent finding.
Right.
I'm afraid that the
every
pressure
other
is
valve
down.
would be happy to have that result.
This is
pressure
another
is
angle.
down.
Very nice.
Depth is high as usually we perform until now. Now the T cross section. Can you see a T? Okay.
The left corner is free.
The left is free.
혈압을 조금 넣어야 되네. Color. Okay, we can see the coronary flow at the 12 o'clock. No paravalve leakage.
Yeah, but
No. Okay, EKG. EKG 리드를 조금 더 키워볼 수 있어요. 아까 you'd like to see the P wave. Still, accelerated junctional rhythm.
Yeah. It's junctional, but it's narrow QIs.
Okay. In my experience, such kind of accelerated junctional rhythm is nothing to do with AV block. Just, I guess, usually in this situation, the rhythm, lower part of pacing rhythm is activated, while the general parasympathetic tone is maintained. The sinus rhythm is low, and low part of pacing activity is high. Then we can frequently see transiently accelerated idiojunctional rhythm.
Excellent lesion.
Is there any comment?
yeah,
Opinion?
the comment is that you did beautifully as expected in a very difficult decision. And I think you showed nicely the ability to reposition this valve by resheathing it to achieve actually the result that you would like to see. And I think it's a great result in a not an easy case. And that was very well done.
좀 자극하면 어떻겠어요? P웨이브 보이게. 혈압도 조금 낮고 하니까. I'd like to suggest an opinion to anesthesiologist to activate the sympathetic tone because the blood pressure is a little bit low now, and rhythm is very stable, about 60s. Because we have time to. How many minutes remaining? 50 minutes? Still? We rushed.
One of the unexpected the hypertension is might be related with some population of the ventricles, so it would be better with a check with a TEE.
But in my experience, we usually put the vasoactive agent. So during active procedure, the blood pressure is a little bit high. Then after completion of procedure, all the drugs are withdrawn. This is a usual blood pressure level for our previous experience. And we always check the echo regarding to the pericardial effusion. T, switch to T. Especially current TAVI system, Lotus TAVI system is very stiff. Thus, if you advance the stiff, very thick stiff shift through whole artery, aorta, is frequently happening that there is a minor dissection of aorta. Do you see the T? There's no significant pericardial effusion. How about aortic arch injury?
Anyone in the panel that would have taken a 25 millimeter valve? Anyone in the panel? Any comments? 23 was good, right?
This Lotus system is very tricky to deploy. Thus, the popularity of Lotus system in Korea is very low. Eberhard R, Sapien 3 is very easy to deploy. But in terms of regurgitation, this is my 13th case, no leakage like this. So I like Lotus because leak is a kind of prognosis factor for the future of these patients. The trade-off is AV block. Thus, our team is really accustomed to high implantation like this case. For that purpose, I usually maintain the distal edge of post above annulus line all the time of the process. Then the final distal part of post match just landing zone or just center or lower third of sinus. In that case, actual distal edge of valve is around the annulus plane, just 1 millimeter lower than annulus plane. In other words, 1 millimeter ventricular. Although the distal edge of valve frame is on the annulus plane, but there is still no leakage because of the remaining tissue around, just above the annulus, and there is an adaptive seal on the prosthesis. In my experience, even though 1 millimeter, 0.5 millimeter ventricular depth, there is no leakage. In this case, I think,
Professor Kim, this was beautifully done. Unfortunately, we have to switch, or fortunately, we have to switch to the other lab. Thank you very, very much for a brilliant demonstration on the Lotus in a very difficult case. Thank you to you and your team for an excellent, excellent case.
Thank you very
Excellent
much.
job.
Yeah. 자, 끝낼까요?